This is not for your normal chiropractors. This is not for your typical physical therapist. This is not for your run-of-the-mill physiotherapist. This is for you. But today we're going to go over some, just a basic case, and maybe go off some tangents. Oh, definitely on some tangents. This podcast is about tangents, if you haven't realized that yet. But today, I've only seen this patient one time, and I kind of want to get Bobby's insights. But so just basic case history. First of all, hi, Bobby. Say hello to the people.
What's going on? I'm just thinking of SOHCAHTOA when you're talking about tangents. So
SOHCAHTOA.
Yeah, sine over, cosine, hypotenuse, tangent. You got me.
No, I don't got you. Tangents already. I love it. I know what you're saying. Those T81 calculators we had that kids don't get these days. Anyways, I have this patient. He's 16 years old. He just went through a big growth spurt. He has pain at his TL junction, a little bit more on the left, but also on the right, kind of, let's just say L2 through T10, T8 maybe, going up a little. He also has, I didn't tell you this before, but he also has pain under his left scapula. Very tall, very lanky kid. He's been to PT. He's had this for about 2 years. He's been to 3 months of PT. They said oftentimes it made it worse after going to his PT visits. And we'll just let the inquiry begin. But I've only seen this guy one time, but I want to kind of get an idea of where to go with this, how to kind of think about this thing, because it seems straightforward. It's tight there. We're going to give him some stretches, some exercises, maybe some ab exercises. We did some tests. He's got some pretty bad weeing scapulas. He has horrible posture. When he sits, he just slumps down like any normal 16-year-old looking at their phone. Very hypermobile hips, passively at least. So seated, he's got like tons of internal rotation, probably say 75 degrees of internal rotation, left and right, maybe 45 degrees of external rotation seated. But yeah, what are your initial thoughts on this one, Bobby?
Well, how tall is he?
I mean, 6'2".
6'2", 16. And I know you're bringing this one up, so there's got to be something that's a little tricky about it for you. Like, was it something not going right the first visit, or a little bit of difficulties that you come across?
Well, I mean, just the chronicity of it. It's a low level pain. So it hurts him after he goes for a walk for about 15 minutes, and it really hurts him. He has to stop walking. He can only walk for 15 minutes, but in the clinic, the pain is only like a 3 or a 4. So it's not horrible. So it's hard to tell in the clinic if what I did will make a massive difference right then, because if it's at a 3 and I get it down to a 2, it's hard to see it. So the big difference, I think, why this is going to be tricky, is that when he sits, horrible posture, kyphotic, one might say, wing scapula, hypermobile hips. But then when he walks, very, very upright into extension.
Yeah. Did you happen to, I'll come back to all those points you just made, but did you happen to ask what the physio or PT did with him?
Yeah. I mean, they said that they would have him warm up on like a recumbent bike, and that just basically being seated on a bike, they're like, be on that for 15 minutes. And that would just flare his back up, being seated on a bike, looking at his phone. And then he'd be like, you're making me worse. Why am I going here? But he went for like 3 months. He went to 18 visits.
Wow. I've never thought to use a recumbent bike for therapy, but well, unless it's like a post ACL reconstruction or something. But okay, getting back to his other points. So he's classically hyper slumped when he's at rest and he's sitting, right? Mm-hmm. Does he play any sports? Is he like a video game kid at home? And what does he do?
Yeah, I mean, I guess you could say he's very deconditioned. He's very thin. He ran cross country. So before coronavirus, that he would run quite a bit. I mean, 5K, maybe 10K. So not a lot, but he could run for an hour or for an hour and a half. Wouldn't hurt while he was running, but then after he ran, he would have pain in that TL junction and under his left shoulder blade. So yeah.
This might be a tough one, but were you aware at all at the curvature of the lumbar spine, like whether or not he had like kind of a curved low back, or was it kind of flat? Was he alordotic or hyper or neutral?
I mean, it looks pretty straight to me, honestly. It's not hyper. It's visibly pretty straight.
Yeah. So in a sense of straight as in more alordotic, like he's losing the curve?
Correct.
Yeah. Okay. Because that makes a little more sense to me with the recumbent bike, because if it was more of a hyperlordotic lumbar paraspinals, hypertonicity, contracture pain, if that was the only reason, I wouldn't guess that the recumbent bike is going to fix anything, but I wouldn't think it would cause him pain. But if he's alordotic or has a loss of the curve, then that might not. Yeah.
So why do you think why do you think the recumbent bike caused him pain? I can hear our listeners asking right now. Why do you think?
Well, like people with larger curves, we can stereotype the J-Lo or whoever out there, Kardashian, whoever out there has these deep low back curves. It looks like they have really big butts. They do better with sitting. Usually they hurt when they stand all the time. Those muscles can't, they have to hold that curvature, because of that curvature, those back muscles have increased leverage and they do better to sit down. It kind of feels good to sit down. They can sit for a long time. But somebody who's lost their curve and then you force them into maybe like a slumped recumbent position while they're cycling, it's almost like you're flipping the bow and arrow around, like you're inverting the bow in the wrong direction.
Yeah.
And it could be a bit of honestly spinal pain in the sense of, not like Mike Tyson was talking about, but it's spinal. But like, in other words, like the spine itself, the joints,
yes.
ligamentous tissue.
Spinal.
Yeah, I broke my back.
Broke my back. I love that clip. Sorry.
And then he tried to clarify. He's like, what do you mean? He's like, spinal.
Oh, okay. Got it, Mike. Okay, cool. Sorry. That's such a great clip.
Yeah.
Sorry. Okay.
Anyway.
It's definitely spinal. Yeah, I agree. So like basically you're saying that when he's in that recumbent bike and pedaling kind of mindlessly while the PT assistant steps away to do another patient, he's basically pushing that spine straighter as he's kind of pedaling. Basically he's pushing that TL junction back into the back of the seat of the recumbent bike. Yeah.
And I don't have all the information, but you did give me a little brief intro before we started, and you said something created a burning pain in him, like a burning discomfort. That was also in my mind when I'm thinking about this, because can you tell me what that was again? I forget, but
you talking about the exercise?
where you stretched something and he actually felt a burning discomfort.
Sure. So we did kind of like a glute bridge. You could start off kind of by saying that, but he's laying on his back and we gave his upper back a little tilt. So kind of think of a hammock. His feet are up on a wall, kind of in a 90-90 position. And so I flexed his thoracic spine, and then I have his feet up on a wall. Both feet are out. So his feet are starting an internal rotation. I put something between his knees. He lifts his butt up off the ground, going into flexion to flex the hips. And then he gets this kind of burning sensation along the lumbar spine up into that TL junction, but not necessarily uncomfortable, like a deep stretching burning. It wasn't like I've got to stop. I interpret it as, of course, I did the right thing and started to inhibit his lumbar spine, and that lumbar spine wanted to work, or you could say the hip flexors on the other side wanted to try to work, but because of the position I had put him in, the knees together and the thoracic spine trapped, he got that burning sensation in his back.
Yeah, I got you. Okay. So, and there could be, I mean, it seems like there's definitely this dichotomy that is a problem here, where he's either hyper slumped or he's too extended. So, you know, you have this thin piece of metal that you either have bent far in one direction or you bend it far in the other direction. It never sits in neutrality. And so, yeah, with that said, I mean, I think there is this dichotomy, dichotomous issue here with the kid, where he's either in full slumped flexion, or say fully slumped, hyper slumped position, or he's too extended.
Right.
So yeah, in my mind, there's many of those type of individuals, and he's 16. He just went through a growth spurt. He's kind of lanky. He's tall. I think of this more with females, but it can also be boys for sure, or grown adults. But often I see, the 13-year-old female, and I always say, you look like Bambi on the ice. Like, you're just so unstable, and they grow and they're not strong yet. Usually boys, some of the strength comes with the growth spurt.
Like your growth spurt?
Yeah, like I just had right there.
It's okay.
I'm a full grown man now.
Sure.
And,
but no, yeah.
Yeah. So, I mean, with like those young 13-year-olds, 14, 15-year-old females, and they're tearing their ACLs all the time, part of that reason is because they've grown fast. They don't have the strength underneath it, and they land kind of awkward, and there you go, you have your ACL gone. Mm-hmm. So I think if we look at this kid, he's all the way slumped, or he's too extended. He's tall, he's lanky, he's thin. He's newly, shot up in height. And I think that's just showing that he has to hinge all the way one direction or the other, because that is his stability now. Like, he's found stability, and I'm wondering how much you thought of this exact idea when you saw him. But to me, that's where I'm going in my mind right now, before I start to, we start to ask about testing and maybe solutions for the kid. But these are difficult in my mind sometimes, and like, I wanted to ask you, does he seem like he locks his knees back when he stands, like standing still, having a chat with you?
Yeah, absolutely. Definitely locks him back. You can also see it when he walks down the hallway, or when he came into my office. His knees just almost hyperextend as he kind of almost like jolts forward, just kind of skips a little. Yeah, kind of that Bambi situation. And the same thing like happened on his, even though he's hypermobile seated, internal and external rotation, like during his toe touch, I mean, he probably reaches his arms down to his knees, but that's only because they're long. Like, from his hips to his spine, like maybe he gets 45 degrees, but then his arms can reach. Like, he can, yeah. He's like, well, I'm just not flexible.
But he's got a lot of flexibility on his far upper T-spine, right? Is he like hunched quite a bit as he reaches?
Most of the reach comes from, I would say, T8, above T8, perhaps, in his arms. There's a lot of flexion there. There's not a lot of flexion below that. There's a little tiny in the hips and a lot at the knees. Yeah.
You don't have, I doubt you have imaging of him, right?
No.
So we do some imaging over here, and often, like in a case like his, he's 16, it's nothing crazy. I probably wouldn't X-ray him anyway, but if for some reason him or mom was like, we want an X-ray, okay, I'll give you an X-ray. Yeah. But then at that point, I would probably say, with that type of person, even though he's 16, I would say I would bet a decent amount of money. Now, I'm not always going to win, but I'm definitely like the house in the casino. I'm going to win big time in the end on these bets, where I would say on this X-ray, we're going to see a alordotic or reversed cervical spine for sure. And I would say 9 times out of 10, I'm right. And I'm always kind of surprised myself when I'm like, yes, okay, it worked out.
Yeah.
I made my money, my theoretical money back. And because there's just no way with those individuals where they're not going to be sticking their head forward. Their face has to move forward to counteract this posture. And they're going to be, like hyper extended in their head. I mean, a lot of times he's 16, maybe he's fine, but these are also headache patients, 10 years later.
Yeah, no, he's still resilient and young, so he doesn't have a lot of other compensations, but I totally see what you're saying there.
Well, I was going to ask you,
Yeah.
what does he do with his hips and his lower body when he's relaxed? What do they do?
Oh yeah, I mean, he kind of will cross his legs. He'll sit with his legs folded out into external rotation abduction, or he'll fold one leg. He also, when he was sitting on the table, and the table's a little bit lower than a chair, I noticed that he will kind of turn his kind of the bottom of his feet together, I guess you could say. So he'll rest on like the outside of his like kind of pinky toes, like going into an ankle sprain, like just flopping his legs kind of out.
Yeah, see, he has ample mobility, but he instantly finds whatever end range he has, because then he's stable. He's like, okay, now I'm fine. Now I'm on Earth. It's no problem. I know where I'm at. But if you put him mid ranges, he doesn't know where anything is. He can't feel anything. And I think you told me before we started something about you gave him an exercise and he couldn't feel hamstrings. He couldn't feel abs. So like, can you tell me about that? Because you're trying a strategy to maybe counteract some of his issues, and he couldn't feel it.
Right. Yeah, and I totally agree with like he's living on either end of the range. He's living on his joints on one end or joints on the other, and he has kind of. So, anyways, I tried to get him to kind of do. He was a bird dog position, hands and knees, basically, and I had him round his back, which was already rounded, and then kind of have him rock forward, like shift his weight forward as he maintains think of the cat cow on all fours. He goes up into the cat. He maintains the cat as he shifts his weight forward. Typically in this position, people will start to kind of shake and they'll feel their abs. And to your point earlier with his x-ray, he was really tightening up his neck. He was tightening up his neck, and he was also gripping his hands, like he was white knuckling his fists. Just two random things that I noticed. But he didn't feel his abs. He didn't feel his hamstrings. And I was like, okay. It was also a little bit of a test. That one's not that successful for me, but I just want to see if they can kind of maintain that position. When they shift their weight forward, usually you're not able to use the hip flexors to hold yourself up, which I know he's doing. Especially the rounded back. He's not allowed to kind of pinch his back, and you'll have to engage the abs, and he just wasn't. Why wasn't he, Bobby?
Well, yeah, it looks like he was using his upper traps and neck and everything to hold himself up, as opposed to getting any kind of core control or any stability there.
So he's just got a crazy stabilization not crazy. It's the stabilization strategy that he has. He is referencing whatever he can to stay upright, and the end range of those joints does have proprioception. He can kind of feel where he is. So that's how he recognizes himself in space, by just resting on those end joints. And he's like, okay, now I'm home. I feel stable here. Except that also causes pain.
Yeah. You could try this next time. Like what you're saying, it just made me think of like getting him to, and I actually think your latest Instagram post would be a good one for this, but maybe with a slight modification based on what I was just thinking. So we'll get back to that. But I was thinking he needs to spend a lot of time in mid ranges, like really getting used to that. So I was picturing, I would say, I want you to lunge down, across my hall or through my office, but I don't want you to fully hit your knee down and relax. And I don't want you to stand all the way up. So I want you to imagine that you're kind of in a small space. And I've never done this before, but it's just coming to me now. But if you're in a small crowded, like, cave tunnel, and you can't touch your knee down because, I don't know, it's hot lava, and you can't stand up very tall because you hit your head on the ceiling.
Sure.
And I just want you to lunge all the way down. So you never get to stretch a hip too much into extension. You never get to stretch, the hips up into nutation, for example.
Mm-hmm.
You have to stay in that mid-range and work it all the way down the hallway or, through the cave. And as as I'm hearing this case, I'm like, you just posted an awesome video where I think it could apply. It could apply because you're strengthening through mid ranges mainly on that exercise, but you're braced through the floor and through the wall. So maybe we can get into that, and I'll maybe see if I can come back with a modification and tie it together.
Yeah, I mean, just the idea would be basically, so let me just kind of outline the exercise and then I'll kind of talk about why. So in the exercise, I've got, I'm probably 2 feet away from the wall. One of my feet is pushing back into the wall, about a foot high. The other foot is forward, kind of like that lunge position you're talking about. And then I kind of sit back like into a squat, and then I do a deadlift. It's like a single leg deadlift, but my back foot is pushing into the wall. And the point of the exercise is to make sure that the back foot stays pushed back the entire time as you go into that hinging deadlift motion. So push the back foot back. Sometimes when I do it with my patients, I'll say sink your weight back into that foot as you kind of flex down, and then push that back foot back into the wall to propel you back up. And as we do that, that is a big reference to that back foot, obviously, but actually more so to the front foot that's on the ground. It almost pushes that foot into the ground. And again, my knees are kind of bent, so it is a mid-range. And so it's really grounding, and you're getting to feel that front foot into the ground as you're going into flexion extension. And so the point is, this guy, he lives at either end range, hanging on one side of the joints or hanging out of the other. This would give him a reference of his foot and not allow him to go into full flexion or full extension with that reference of the foot. That would be the main reason to do. I haven't given this exercise, but I do think you're right. It would be. How would you modify?
Well, I would say not necessarily a modification, but something that you would look for. Before I say that, I was going to say how this idea where he has to stay in mid ranges and feel the floor, like feel the front foot and feel the wall foot. I think that's a better option. Like you said, you clarified and you said, I think just using my all four position like a test. It's because I don't think that one would work actually either, because there is no awareness of the ground. So even if he felt his abs, even if he felt everything he was supposed to, maybe when he stands up, his operating system just puts him right back to the same things that he does all the time anyway. His habits, if you will, his operating system is going to put him back into extension and then slump him when he sits. So he's got to have that reference from the floor, like for sure. But I wouldn't say for that exercise I would have a modification. I think I thought of your exercise because I think I asked you, like, did you do that for that kid? Because that would be a good one. And but I think he would either really try to default to, if you let him hinge too much, he might start to use the upper trap and the neck again. And he also will have a tendency to either be too rounded as he descends, or too extended. Like I feel like you're still gonna have to watch him to make sure he's not using his low back to do the exercise, even though it kind of makes it hard for you to use it. But he might still try to use it, or he might hyper flex like mid spine, or mid T spine and up, like you were talking about in his toe touch. He might try to do that strategy along with overusing his neck and his upper traps to hold that weight. Even if he didn't even have any weight in his hands, he would probably do it.
No, that makes sense. I mean, because back to the specifics of his case, obviously his pain is provoked when he goes for a walk for about 15 minutes. So when his feet are on the ground, i.e. somehow he just starts to use that low back over and over. He doesn't engage some of those prime movers. He engages that TL junction. And so I could see how the feet on the ground would start to make a difference for sure. I actually, I mean, I'll probably do that, but also in relation to that all fours and his fist clenching and his neck tightening up. You're calling it on the imaging. I actually I do think his psoas, your post of you doing a psoas stretch / row, would have a more kind of a top-down influence on him controlling the top of his body and his lower. Maybe, and I don't know if it would be a perfect, input to this particular case, but I do think having him row and move his thoracic spine. Could you walk through your post?
Sure. Yeah. I mean, so for anybody who doesn't know, I mean, what's today's date? It's the 31st of May, 2020. So
no, it's Tuesday. We just released this on Tuesday.
Oh yeah. In a couple of days.
Uh-huh.
But yeah. So what would that be? The 2nd of June, something like that.
Sure.
So if you guys go back, these posts are back to back, where John and I posted these. I don't think it would be the best one for him again because even though one foot is on the ground and the back foot, the toes are on the ground, you're stabilizing usually kind of through your knee, and I don't think that would transfer as well to upright for him. But if you were trying to teach, I think you could easily show him that he probably can't row a cable without extending his back or flattening his T-spine. He definitely wouldn't be able to keep a good position. So this would be a scenario where it could teach him maybe what he's supposed to feel, and then you could kind of carry it into something, maybe more useful, or it'd be an accessory exercise to what you're already doing. So
to your point, that actually reminded me of one fascinating thing about this case. This is actually the reason I brought it up in the first place, and I can't even remember podcast twist time. He describes when it feels that, like, he's like, it kind of aches, it pulls, it burns. But I was like, how would you describe it when you're, it hurts when you're sitting, or then, once it starts to hurt, what does that back feel like generally? And he described his back, his abdominal area, that rib cage and lumbar spine. He's like, it almost feels like nothing. It feels like an empty void. It feels like there's just space there. It doesn't feel like anything. And I was like, are you getting existential on me, bro? Like, is this quantum physics? We're talking about false vacuums right now. But he's like, he doesn't feel it. When asked to describe it, he says, feels like nothing. It feels like emptiness in that mid.
This was the same patient, right?
Same patient. So you're talking about we're talking about referencing things. We're talking about referencing the ground, talking about referencing the arms or the shoulders or his abs. Like, patients need to feel particular areas engaged. And he actually was far more intuitive, I think, than a lot of patients in saying this. It wasn't actually just this kid doesn't know how to articulate what's going on. I actually think it was one of the better articulations of that ever, because when he does slump down or when he does walk and hyperextend, then he does feel something there. Otherwise, there's no reference. And this is the point, I think, of what we're saying with the foot reference and with the single leg deadlift. You have to be able to feel something, whether you are conscious of it or not. You know what I mean? Otherwise, your body will force that reference, and his reference is just jamming onto those joints, hyper or tensing up those muscles. Is that fair to say?
Yeah, that you right at the end there. That's what I was thinking the whole time. Because if he doesn't feel that area, the TL junction area, he probably for sure feels like L5S1 area. I mean, he may say maybe he doesn't feel the muscle, but he just feels pressure, or he feels something there. He has to be. That's got to be his hinge point where he rests on, especially in stance. He'll probably feel his upper shoulders, maybe that left shoulder blade that we haven't really talked about, or his neck in general. We kind of, we've been all over the place on this episode, but I briefly mentioned that you said his hamstrings and his abs are hard to feel. I think some of these mid-range stabilizers, the sense is off for those, but end range stabilization, whether it's the end range of a calf or the end range of a certain muscle, like a neck muscle or a suboccipital, or an end range of a joint, which is more what you just said, and I think I agree, which is like an L5S1, not exactly, maybe just, but you know what I mean, that low lumbar spine,
right?
That is a compression end range stability. So he's finding end ranges to feel things.
Yeah, it's getting heavy. But yeah, like he's living on those end ranges. So any kind of extra will tip him over the edge very quickly. You know what I mean? He's not hanging out in the middle in a safe place. He lives on the edge, literally. And so any extra stress capacity, simply walking, living on the edge, he falls off and goes into a painful strategy, basically.
Yeah, you definitely should, test him in some of these mid ranges. And if he's just a wobbly baby deer everywhere, you know what I mean? He can't hold scapular protraction for any decent amount of time. He can't hold a plank for any decent amount of time. He can't do, that walking cave lunge that I was talking about.
Yeah.
It's just burning on fire instantly. Then I think you're 100% right, because any little extra stress, those things they'll fatigue out fast because he doesn't use them. And then he's going to be just for sure a greater version of himself. He's just going to maximize his self. You know what I mean? And he's not going to feel anything besides those end ranges after that, because
he's maximized living is what you're saying.
Maximize living. Yeah. He should see those guys.
For sure. No, but I do think that this is our actual reason for bringing this case up. He is living on those end ranges, but I do think, and it's a very obvious living on the end ranges with this guy, but I do think a lot of patients that is how their pain kind of comes about generally. And sometimes it's harder to weed out than it is with this kid, because he's just his authentic self. But like some of our patients, it's harder and harder to see where they tip over the edge. It's not all the way flexion. It's not all the way extension. Sometimes there's this weird torque and kind of twisty thing. But that's the idea of any kind of injury, whether it's a break or a snap. I take it to the end range with say a bone. A bone will break if you put it under enough tension and stress. And sometimes it's not necessarily, you don't see a whole femur snap. You just see there's too much tension and torque going through a right levator, upper trap or something. And that combination of torque, twist, and stress that kind of through whatever specific pattern and movement tips that area over the end. And so not only do you need to get that area to relax and back into some sort of resting state, but finding the thing that also wound that up. And with him, it's just obvious because it's all the way flexion, all the way extension. Mm-hmm. But I do think it's much harder to figure out with the general population.
Yeah, I agree with that, figuring it out, but I would still be hesitant to call this, even though I'm sure we nailed it and we got everything right about this kid. Totally. I still hesitate to say that it would be easy path for him, because I mean, you could give him some stuff in mid-range, but maybe he doesn't have any strength to even do it. So then you got to go back and maybe build up the strength doing something that's not about sense. So you have to go back to something like planks and lunges and whatever you can do just to build up his muscular endurance in those areas. And then you go back and try to make him feel things, because now he can hold something. Otherwise, he's just going to lose it anyway. So I still feel like I agree with you, but it's still going to be tough, I think. I could be wrong. He's young. He's not, he hasn't spent 20 years in this pattern. So he could get out of it. He spent
2 years. I do think like the way forward though, especially with all of these different things, is with the exercises. And we had the Dr. Zach, the sports physio, on, and he does a lot of DNS exercises. And one of the kind of concepts in DNS is their reference points, their fixed points, punctum fixum, punctum mobilum. But these fixed points, these reference points. So if we give an exercise, so let's just say we go with like a plank, and you're on your elbows and you're on your kind of toes and you're straightening, your body in between. But what is it you're focusing and thinking about? Like are you thinking about keeping your abs up? Are you thinking about keeping your shoulders back? There's a million different cues you can do for a good plank. So like, for instance, I do think, and the PRI people talk about this quite a bit, the the reference of a sternum, right? The where that sternum is kind of pointing at. The DNS people have that bottom of the sternum. They also have these points kind of underneath the bottom ribs, just under the chest. This is the triangularis sternum. That muscle is one of the DNS points, and that's kind of a point to focus on as well. They have the ASIS. So like, I'll probably give him more of his sternum in that plank position to think about, because there's so many things you could think about.
Well, that's a good point on tailoring. Like if you go on YouTube and you say, type in the best plank or the correct way to do a plank, sometimes those ideas are good and they're better than poor planks, right? They're better than just hinging on your back and being scapularly retracted and just hanging out there. But it can be so individualized. You can see how a plank you could cater it just to that boy, right? So for him, maybe unlock his knees, maybe make him do something like Mike Robertson's, well, at least that's where I learned it from, the bear exercise, which is kind of like a plank, kind of like the thing you mentioned earlier, but he's on his toes, but his knees are off the ground, but he's more in a flexed position, more like a squat. So he might be somebody where I would say, hey, I need you to unlock your knees. Maybe you could even put his feet up against a wall in a plank position, unlock his knees. And then you can say, okay, you already hinge fine upper sternum manubrium area. We got to get you to hinge maybe xiphoid area. So you could kind of point out, so you can go through and say, this is where you got to feel this. See how you feel your abs, but you're not super rounded in your back. I need you to protract a little bit through the floor, through your elbows, because for you, your serratus is on holiday. They're not doing anything. You see what I mean? So it could have a posterior tilt. Can you do that while you bend your knees? If you can't, that's that. Okay, we have to take a lateralization or regression off of that exercise to feel that. There's so many things you could do to individualize that for your patient or the person who's sitting in front of you.
Right. And I think like back to that single leg deadlift one that I posted, like I like to give that a lot for like foot pain, for like plantar fasciitis, and have that. Sometimes we'll just do it and I'll have them push their foot and I'll ask them before we correct it, where do you feel the weight in your foot? It's on the outside, it's on the inside, it's on the front, it's on the pinky toe, wherever it is. And then we can have them kind of correct it, like move it to the lateral heel, push the first ray down. And really work on that as you kind of go through a little flexion extension through your hips, but keeping the first ray down, or rather kind of pushing, just feel the overall inside of your foot, inside of your heel. I think that's probably where I would go for him. A lot of times it seems a little bit counterintuitive, and I would have him, a lot of people that overpronate, right? Their midfoot kind of goes down, but feeling that on that single leg deadlift, feeling the inside of that heel more so than the inside of the arch, because that arch is falling down to try to find some reference, kind of like we're talking about with this guy, but feeling the inside of the heel as they go through a little bit of that flexion extension to reference. But especially in the beginning of these cases where there's so much, give them one or like two references, because then they go, what muscle am I supposed to feel? I'm like, no, you need to feel as you go through this hinging motion, just maintain pressure on the inside of your heel, back and forth. Do I feel my abs? Do I feel my glutes? Is it my glute med? No. Let's focus on referencing one point as you go through a specific motion. And that has really helped me kind of fine tune stuff. And then you can build on that in subsequent visits. But you really have to, I think, refine down to one of those points. What do you mean with, let's go back really quickly. Xiphoid, manubrium, in terms of like the kyphosis, what is this, the sternum as a whole, have to do with posture? Shouldn't you just pull your shoulders back, Bobby?
Sure. Yeah. He could do that if he just never wants to get better. And I do want to come back to what else we could give him, because for one, he's coming back in to see you. But please. I also maybe could bounce off ideas, and for me and you personally, but also for any listeners, what else he may need. What other exercise could we come up with?
Let's do that we'll go back to the posture at the end.
Okay.
Oh yeah.
It doesn't matter.
Help me with
I
this
was,
case.
I was thinking, I mean, it takes time to go through the library in your head. And if you don't take time, then you're going to give the same things to everybody. So, but I was thinking, and I actually don't give these very often at all, but different types of crawls or animal walks, I think would be good for him. And I say animal walks because there's like the lateral gorilla walk. Do you know what I'm talking about?
Yeah.
So you're like in a full squat, then you put your like fists on the floor, and then you move your lower body, then your upper body, and then you're up, or vice versa. So you can move your fists to the left, push them down, and lift your lower body up and hop over to back to your original position. Things where he's reaching and he's pushing, but I even though he sits in a lot of flexion, he sits in a hyper slump position, I think he would probably do well with things where he's folding up his lower body. Just to get, I mean, people need to get their knees, their like the mechanoreception and proprioception of their knees back. I have just people that can't squat even close to 90 degrees. And I say, you know what? You couldn't poop if there were no toilets. And toilets are an invention from us recently, very recently. So I don't know what you would do. You would just have to hang from a bar or maybe fall over in your own stuff. I don't know what you're going to do, but you're in trouble. So I do think those ankles and those knees and those hips, they do need to feel those end ranges in the other way than he probably doesn't do enough of. But even bear crawls, to me, that's not going to carry over maybe perfectly to upright, but it is a mid-range activity where maybe slower bear crawling, maybe like you do like the bear exercise, and then you start to shift, right leg, left arm, and then just vice versa, and work your way down the floor. Anything come to your mind? I also thinking of something with rotation, by the way, some kind of thoracic rotation with him.
No, and I'm not opposed to. So, say for instance, let's talk about back to the end range thing. Even in the flexion, like I know a lot of therapists kind of are opposed to shoulder shrugs. You may see the big dudes in the gym lifting heavy weights up into the shoulder shrugs, right? I've seen people in the plank, go in a plank or some exercise, they'll do a general rotator cuff exercise and then shrug their shoulder to do external rotation or elevate the shoulder blade. And when they're not meant to elevate their shoulders. And, so they'll say, it's also a kettlebell thing. Keep your ears out of your shoulders, keep your shoulders out of your ears, that sort of thing. However, I'm not opposed to even allowing that if it is in a controlled way. Because the deal with people kind of bringing their shoulders up into their ears is it just happens. No, they're not like consciously like, let me go into this posture. But if you can, we can define, one of my favorite definitions of strength is the ability to go in and out of a position. And most of the patients we see are stuck in a position. And so sometimes you have to go in and then back out. So even letting him do some of those shoulder shrugs or the end range thing to go in and then pull it back out in a controlled way isn't a bad idea, especially if you're not going to be able to give him 1,000. He's 16. It's summer now. Like he just wants to, hang out with his friends and be on his phone and TikTok or whatever. So like you have to give this kid, he's going to need some simple stuff. And I don't specifically think that I'm going to give him shoulder shrugs. But your idea of working at those end ranges, I'm okay with. I'm very, very okay with. Even if it is shoulder protraction and retraction. I do think keeping those shoulders pulled and pinned back is a bad thing, but then going back and then letting go forward, going all the way back. And so instead of end range, him using his joints, we're starting to get those muscles to work at end range. So we're bringing in even more recruits at those end range. And again, recruiting the muscles at end range rather than the joints, but then ability to go in and out of that thing. I do think, and that's exactly your point with the knees, I believe. And so I'm thinking of the same thing with the shoulders. I'm going to have a different partner this week to help me with my exercises. And sometimes it'll take a second to instill concepts. So we'll have to, I don't mind doing some traditional exercises, just with one little twist, like, okay, shoulder pullbacks are good. Okay, with this little thing, let them go all the way back and then let it out. That same idea. So we'll use some very traditional I's, Y's, and T's. I know that there are some physios and PTs on the internet that like to bash these traditional exercises. But if you're a good enough therapist, you can use them and just give them a little twist. Just put a little salt and pepper on it and make it your own.
Yeah, but it's not twist for the sake of twisting, right? It is because you are making that exercise more relevant to that individual in front of you. That's the point of the twist. So when you brought up the exercise of me in a lunge position, doing a row, one arm cable row, while I was, in the post, I was hinting that, hey, you could stretch your hip flexors and you could actually be in a better position to row, and you might even use that row to help you stretch your hip flexors more than you would in a regular stretch. Absolutely. But also you could tell somebody, okay, they need to be stronger at rowing or retracting or posterior musculature of the shoulder. But if their strategy, if this boy, this young, the 16-year-old, his strategy to pull anything is to push his spine forward as his shoulders go back, that's the only way he knows how to pull. Then his head is also going to go forward. He's never going to be able to do anything without his upper traps. He's got to be able to do, that's one way. You can pull and you can extend your back as you pull. But another way would be to keep your, let's say your sternum, as you brought up earlier, down or less pointed forward in a sense, or extended in a sense. You're keeping your abs on, and you actually have taken shoulder blades that maybe look like they were winging and now they're compressed against the rib cage. They're more, and when you row from that position, if you can do that, that's a different strategy to row. And I guarantee either the weight's going to have to go way down, or he's going to feel like it's super difficult, or something else. But you see how you can tailor those things to the individual that's in front of you.
I mean, the idea, those higher level concepts of breaking a pattern. There are people that, like I said, people are stuck in a position and we need to get them out of it. And if we just go to the cookie cutter I's, Y's, and T's without understanding the concept of A, where the patient is at, and B, what the exercise is trying to do. But if we can kind of meld those together, you should be able to specially tailor those to the patient. Rather than, and this is the other thing too, I actually saw a guy this week on social media, Charlie Weingroff, was talking about how he is now, I'm paraphrasing him, don't misquote Charlie, but he would be very anti-machine working out. Very, very anti. And there are a lot of people out there who are like, machines are the worst. They're a natural man-made. But here's the thing. A lot of your patients, a lot of real people out there will only work out on machines. They're not going to do the animal flows. You know what I mean? They're not going to roll around on the ground like these dancers. They're going to sit and be fit. And you have to give them something that will work for them, something that they will do. They're not going to go out and buy maces and Onic Gorilla, kettlebells. If they do, that's fine too. I love those things. But if you can give them something where they go into, 24-hour fitness, Gold's Gym, Planet Fitness, and you can tell them to cue them a little differently when they do their, cable rows, then you're helping that person. Does that make sense? You have to be able to live in their world a little bit.
Yeah, and I was just thinking of strength coaches in this situation too. Man, if there's any strength coaches or personal trainers listening, I feel like this is an area where you can help more than we can. I mean, you're with them, you train them. There's so many ways where the way you would stand out in your field against all other trainers would be your ability to individualize, not just like, hey, this one's for Steve because he needs a little bit more bicep and he needs a little bit more tricep. No, I mean that individual, you can maybe prolong their career, you could prevent injuries, you could increase performance, you could do all these things by seeing what they're not doing well based on who's in front of you. For example, winged scapulas don't look good on the stage if you're a bodybuilder. you're not going to be able to see, you're not going to be able to build great musculature around the posterior scapular region anyway with a wing scapula. You're not going to be able to see it if you had it. So for example, knowing how you can take that person in front of you and tweak it in a way that's good for them. I'm just saying it's great for us clinicians, but I mean, as a coach too, whether it's performance or physique or whatever it is, I mean, that's a big deal. And that's a way to stand out.
Yeah.
I did want to close a little bit maybe on the idea of that left shoulder blade. Maybe if we can do it in like 2 or 3 minutes, because this is why I thought for TL junction anyway, I'm thinking of rotation or transverse plane to some degree. For him, you have to start sagittal. His whole problem is slumped or extended, right? You have to start in the sagittal plane with him. But I think at some point, because you said his TL junction was a little worse on the left than the right, and he has a pain in his left shoulder blade, not the right. So at some point you will, unless he's fine being 90% better, which many people are, you would probably have to address some form of rotation. Like, wouldn't you agree?
I fully agree. And my idea most of the time in treatment is that I am going to probably do 25 to 50% more than I probably need to, because I don't think that you're going to live up to your end of the bargain in doing your exercises and all those things at home. So I want to get sagittal plane, lock that mother in. Then I'm going to get frontal and transverse all in treatment. And I'll try to get you a little bit further. I'll get his left obliques and inhibit his right triangularis sternum in the office so that when he goes out, all he's got to do is work on his ab exercise and his hip flexor stretch. Because I've just pulled him, I'm trying to do way, way, way more. I'll sneak in an upper T4 thoracic spine rotation. Anyways, so to get back to your question, why is it a little bit more on the left side? Why does he have that left scapular pain, not on the right? Okay, so he is right-handed. He is a little bit more, let's just extend it on that left rib cage. That left rib cage is somehow, you can visualize that the left side is just a little bit more forward than the right. Or in terms of the entire rib cage, the whole rib cage is a little bit, the right side is coming backwards. It's all overextended, but that left side of the rib cage might be more, the front side might be inhaled, the back side might be exhaled, internally rotated. Is that fair to say? Now revisualizing this, but just imagine that left side is more forward. So his left shoulder blade is popping back. His left side musculature is extending in the spine.
Yeah. I'm following you. And I think certain individuals out there who've taken some of the courses you've mentioned already in the podcast would follow you. But I think if you're not following that at all,
that's fine.
I would just say that if it's something like that, where you have a left TL junction, like he's got a spot that's always killing him in the left shoulder blade, it comes and goes all the time. If he does something too much, it comes back. You got to just think something's different left to right, period. Because otherwise you would have uniformity of the issue. You would have, I mean, there's a big difference of what I'm thinking if I hear both paraspinals hurt when I walk or just one, right? So if you see more winging on one shoulder blade, if you see one shoulder, they always keep it low when they walk. They're not alternating a low right shoulder, a low left shoulder, a low right shoulder. They're just always holding themselves in one position. You can check, you can just have them seated and squeeze something between their knees and have them rotate. If you see one side is much more easier for them, or they can breathe in that position much better, which John was getting a little bit into the inhalation, exhalation. You can also go follow Zach Couples if you want to learn how to inhalation or exhalation strategy your entire body. Sometimes I love him, but sometimes he's talking about like an exhalation strategy for your abductor hallucis. So, but you can go follow him, because if you really want to learn a little bit about what's going on, especially he's great with rib cage mechanics, pump handle mechanics, and what's going on in these positions. So, but I'm thinking left to right, we got an issue at some point, and John kind of described it. And if he's twisted with his shoulders one direction, he's twisted with his pelvis the other direction. There's just, otherwise he would walk in circles all day, and he's probably not going to do that. So that's where the testing comes in too. So to try to figure out, why is he being held in a little bit of a twist or a rotation? What is he not using? What can you turn on? But again, this is later stage. I don't,
First
get
is
too mired in the minutia.
no. Let's just get really quickly the strategy for that. I would say for twisting him. Let's say I've got him sagittally. He's shifted backwards a bit, a little bit more neutral. I like a good thread the needle. Let's just keep it really simple and use a thread the needle, and then I'll make it specific. So they thread the needle. Let's go say you're in child's pose. And for him, we'll start with the right arm. The right arm reaches across his body underneath the left arm. Now, what I like to do, and sometimes they'll feel a little stretch, sometimes not. This is more of a DNS point, but the spine of the scapula. So he's reaching his right arm across his body. That right shoulder's kind of down, and I'll put my hand along the spine of the scapula and I'll say, push back here. And they will keep that spine of the scapula as a fixed point, and they will push their rib cage back into that position. Does that make sense? To meet the pressure there, because I've stopped their scapula. They'll feel pressure there, and then they get a big stretch between those shoulder blades, mostly on the right. A lot of times you get the back of the shoulder. So for him, that's also, if that right side's coming back, then that left side must be coming back. And then the idea is, after I've had them do that a couple of times and they can feel pushing back into that right shoulder blade, that left hand is on the ground, right? And so they're using their left hand almost like a one-arm push-up to push their left hand back and put pressure through the back of the right shoulder. So this is an easy little twisty thing. And once they can kind of get that sense of using their left hand to push back through the right shoulder blade, that turns that rib cage back into the left, forward into the right. And we'll do the same thing on the opposite side. I'll do that on the right side first because he is right dominant and he is mostly going to be right reaching. So versus reaching his right arm, we need that rib cage to counter the reach. And so he'll reach his right arm typically, but he won't have anything else to counter. And this is a whole other case. We're going way ahead and we're just making some stuff up. But that thread the needle is super money. Anytime a patient, most times when patients say I have pain when I reach, they're getting the thread the needle exercise. They're going to be able to push that shoulder blade back via their other arm and correct that kind of alternating mechanism.
Yeah, I like it. I think for most individuals who have, maybe flatter T-spines, pain in the TL junction, hyperlordotic, maybe standing with their knees locked back. I mean, a lot of these individuals would do very well to get thoracic rotation, and because they guaranteed are compensating to get it in those positions that I just described. And I'm often telling patients, you can't hit a ball out of Yankee Stadium or out of Fenway in that position. It's just never you're going to be a terrible baseball player and you don't really know why you can't do it or why you're a terrible golfer. You've got to be able to inhibit some of those positions in order to rotate. So if you can teach, and thread the needle is kind of nice because you're getting out of extension a little bit. There's a lot of the ones when you're on all fours and you put your hand behind your head and rotate, but you're twisting into more extension on some of those issues. I think if you gave him that one, he might feel worse in his left rib cage afterwards, because a lot of times you say, well, what the hell is that painful point in the rib cage coming from anyway? Well, a lot of times it's this torque stress that's going through a set of ribs that are demanding you to extend them and twist them at the same time. And they start to ache, and they're quite, the costovertebral junctions are quite innervated, and they don't really like to have shear force on them, or, a translatory force between two ribs going in opposite directions, or a compression on one side of the rib cage, and they never get to decompress it. For example, like in this kid's case when he's standing.
But there's, and especially with that one, because I was a big fan of that one in the beginning too, but there's a big difference, especially when you say thoracic mobility and then they're just moving their arm, then say shoulder mobility. Because a lot of times that's all those exercises are really doing. When it's a half warrior, one arm's reaching back, or they put it on the back of the arm, then you're getting, say, scapular mobility. Fine, that's what that's doing. But you cannot guarantee that you're getting thoracic spine, thoracic rib cage mobility when you're going into those extended positions. It's possible, but what I see moving is a shoulder, it's a humerus and a scapula primarily. That's why the flexion, the thread, the needle give me a little bit more thoracic and thoracic spine, rib cage and spine movement. The bang for my buck. It's not impossible. For that one though, because people do need to move their arms, I understand that's how people move. I like the vampire one. So rather than going forward, they reach across their body, like you're going to sneeze, you kind of sneeze into your elbow. They'll cradle their neck and then kind of pull backwards, if that makes any sense. Maybe I'll put a video up on the Instagram this week of that one, because that does kind of lock up.
Yeah, you can take the same one I mentioned of being on all fours, put your hand behind your head and twist, and you could try to unlock that rib cage a little bit and allow for that by doing something that's a little bit more advanced. But you would put them on a box maybe and have them do a full depth squat, hold a kettlebell with one hand, and then they can reach up towards the sky. You can find this one on YouTube, but that kind of ensures a little bit of, what we say, like approximation of the scapulas against the rib cage, as well as a little bit of better sternum position because you're in a deep squat. And then you might be getting some more genuine rotation if it's not just an arm waving like John mentioned.
Yeah.
So,
I think those are some really good ones. We'll have to put some of those up on the Instagram this week because, end of this podcast, we've dropped a bunch of gems. I hope people stuck around for it. Yeah. For those of you that did, we appreciate it very much. If you haven't followed us on Instagram, follow us or subscribe on YouTube, download our podcast, share it with your friends. Tell them they're dumb and they need to come listen to us because we pretend like we know it. No, I'm just kidding.
Share it with your professors.
Share with your professors.
They won't like it at all.
Or you know what? Don't share it. Keep it your secret and just become awesome like we think we are. And humble. Now, that's the trick. Anyways, thanks for listening this week. Tune in next week. Follow us on Instagram. Have a good one, y'all.
Au revoir.